Welcome to State of Reform's virtual series, 5 Slides We're Discussing, with some of healthcare's most thoughtful leaders. And now, the host of State of Reform, DJ Wilson.
Well, welcome to this virtual conversation here at State of Reform. My name is DJ Wilson, one of the hosts bringing you today's conversation focused on strengthening the behavioral health system here in Oregon. And we're super excited to have you. Thanks for filing in. I see a bunch of names of folks that I miss seeing. I miss shaking hands with and giving hugs to. One of these days we'll all be back in person, but that day is not today. We are here virtually, and we've got a great lineup of speakers here for you. Of course, before I introduce those folks, I want to make sure you know it's not rocket science, that the chat box on the right of your screen is a great place to post your questions and your comments. I have one already started there, and you can see there's a little thumbs up icon. So as you see questions that you like, that you want to make sure are integrated into the conversation, please go ahead and post those and then upvote those so that I can see your prioritization, and we'll make sure that we get those integrated into our conversation here today. So without further ado, let me introduce our panelists here today. We have Dr. Mike Franz, as in Hans and Franz, from Saturday Night Live from 20 plus years ago. He's a medical director at for behavioral health at Pacific Source. We have Marie Wacker, the CEO of DePaul Treatment Centers. We'll find out about what she's working on, including name change here in a second. And Dr. Paul Geiger, the medical director for behavioral health at Providence Health Plan. Thank you guys for being here. I appreciate it. Let me ask each of you, and I'll start with you, Marie. What are you working on these days? Tell us about what's occupying your attention.
Well, first of all, just a little bit about DePaul. Our services are across the full continuum of care for drug and alcohol and co-occurring mental health disorders. We practice integrated behavioral health services and employ both behavioral health and medical providers. And we provide services for members of the Oregon Health Plan, which is Medicaid in Oregon, as well as those covered by private carriers. Like many of you, we have struggled to meet the demand for behavioral services in a pandemic world while completely upending the way we do business and deliver services. So that occupies a lot of my time. And second, or probably equally, would be the fact that I'm spending a lot of time over the past year working with our team of professionals to build and launch a new state-of-the-art treatment center that will open this fall, while we are undergoing a identity and rebranding to become Fora Health Treatment and Recovery.
That's a lot. Building, getting, boy, it's a lot going on. Mike, top that. Tell us what you're working on. It's a hard act to follow.
It is a lot of similarities there. Definitely just the increased demand for behavioral health services as we're seeing the prevalence skyrocket. I know we've got a slide or two on that coming up, but that's really been occupying my time, but not just simply by increasing supply of services. What we're finding is we've really got to make sure that we're getting value out of those services and we're getting outcomes, and trying to make sure that we get the overall behavioral system of care positioned so that we can do that in the right way, get our members to the right service, right place, right time. And that's been very challenging to do with limited resources in that space, but working hard on it.
Yeah, great. And Paul, how about you and the work you're doing at Providence Health Plan?
Well, I'd say I'm developmentally a few years behind Dr. Franz here in that my role at the health plan as medical director for behavioral health is a relatively new role. Providence made the decision to carve in or integrate its mental health benefit. We had been, carving that out to a third party for many, many years, and we decided, with the national movement to kind of whole person care and integration, that the right thing to do would be just to kind of bring that in-house. So we've done that, and the first half of this year for me has been dominated by just getting that up and running. We had to develop a network. We had to get all of our policies and procedures in place. It's been really busy. There's a lot of unknown unknowns that has required extra time. So we're just really kind of excited about that. But we think it's the right model. to have that integrated. We think the carve-out model is on the way out. And so we're really excited about that. And then, once we kind of catch our breath, I'll be able to kind of do the kind of higher level things that Dr. Franz is talking about.
Great stuff. I love that we have three different perspectives, even though we have two plans. Of course, both plans work across a lot of different lines of business. So we're excited to jump into this. Two quick administrative matters. One is, first, thank you to Care Oregon. They underwrite these virtual conversations that allow us to do this for free so that people can come in and just engage and continue to drive conversations and continue to collaborate across silos. So we couldn't do it without Eric and Jeremiah and the folks over there. So thank you to Care Oregon. Second, the premise here is that we want to tee up 5 slides, 5 graphical illustrations of some of the more complicated challenges in Oregon healthcare today, and then wrestle them to the ground a little bit through conversation. So we're in a multimedia space, and that's certainly what we're trying to do here with this. So this first slide is one that we've contributed to the conversation. It shows the self-reported data from the U.S. Census Department survey called the Household Pulse Survey, which asks people every week about their mental health, among other things. And the numbers recently are that 41% of folks responding are saying that they are having struggles with anxiety and depressive disorder. It's actually even higher than that if you start to pare it down to maybe just one day a week versus multiple days a week. But the story is very clear, I think, in these two charts, that people are struggling with mental health, struggling with anxiety, they're struggling with depressive disorder. And I think this is going to be personally something that stays with us for a generation, that just like some of us can remember stories about grandma and grandpa with wads of cash in their box springs because of the trauma of the depression and the failed banks, we're going to have little kids today who will never feel comfortable in a restaurant. They'll never want to hug people because of the fear, and we are together this kind of bridge generation. So bridge generation meaning we remember the depression trauma and we can foresee this trauma in the future. So Marie, let me just ask you to start us off. What are your thoughts on the people that you're seeing in your service centers in terms of the anxiety and depression? How is that becoming manifest? How is that leading to other disorders? What are your thoughts on this slide?
Well, we absolutely have seen a dramatic rise in the number of people accessing treatment. The acuity level of their disorder is at magnitude. Many people have relapsed in having spent some months or years in sobriety, and so our teams are definitely overwhelmed with the demand for services. There's no question about it.
Paul, I wonder if you see, we used to talk about like gateway drugs, right? I wonder if anxiety and depression are gateway diagnoses that lead to other things that become manifest that are even more complicated to manage. Is there a connection there?
Yeah, I think, alcohol in particular is an anxiolytic. And so, during the stressful times, not a huge surprise that people are using more. I think the other, maybe even more important driver of the alcohol use issue in particular, which is, I think, kind of universally increased during COVID, is lack of structure. So folks are used to getting up at 6, being in their car at 7, being to work, with work at home and the structure changing. Those kinds of perhaps natural barriers to use have been taken down, and so you can and people have talked about this, right? You can start drinking around 3 or 4 in the afternoon, right? That those barriers are not there. And so I think that for those folks who are either kind of in recovery or susceptible or anxious, the combination of kind of the anxious time and the lack of structure, I think, is leading to an increase in substance use disorders, particularly alcohol.
So Mike, how about these kind of pandemic impacts, how are you seeing them manifest across some of these different lines of business? Pacific Sources engaged in Medicaid and in the commercial market and has a Medicare line of business too, if I recall correctly.
Correct.
how do you see variations in terms of anxiety and depressive disorder?
We're really seeing a universal elevation in prevalence across all lines of business. As a child and adolescent psychiatrist, I've been especially impressed by the effect on adolescents and young adults with what they're struggling with missed events, really landmark events in their lives that they haven't been able to participate in, possibly leading to some arrestment and development. These folks are awfully resilient, though, so I'm going to be a little bit more optimistic maybe than DJ you were as far as the effect on this a generation later. I think these folks can recover from it, but I think our younger folks have even seen an increased relative spike from what I've seen in the data compared to this baseline data on the slide in front of you that's disproportionately affected, especially older adolescents and young adults who by their very nature are really, at their social peak. That's their developmental tasks. And for them to be so limited through the pandemic and the restrictions, their mental health has really, really struggled. And that's probably the population I'm most concerned about. And that's going to skew more towards Medicaid and commercial, of course. But our older adults, too, who tend to make up most of the Medicare population, they've been a population that struggle with loneliness to begin with at a relatively higher baseline, and which definitely leads to behavioral health issues and complications. And with the pandemic, that's just been magnified. So it's across our entire membership, unfortunately.
And adolescents in particular, were already struggling, we think, because of social media, right? I mean, they were already had about the worst mental health status of any adolescent generation in recent decades.
Yeah, there's still some hypotheses out there. I don't think anyone has definitively confirmed why the spike started, but it did occur to jump around 2007 with the onset of smartphones, and I think that certainly looms large in the potential etiology, but it's likely multifactorial. And yeah, you're right. I mean, some very worrisome data, even pre-pandemic, of adolescent girls having prevalence of true major depressive disorder, 1 in 4, 25%. And now we're even higher than that. So you just think about that. 1 of 4 of our children in our homes has a major depressive disorder. It's extremely disconcerting.
How do you see, Marie, how do you see kids and teenagers present in some of your treatment centers? How are you grappling with their treatment differently in COVID than before COVID?
Well, I would say that, first of all, we are one of only 5 treatment centers for youth. Actually, one just closed. The Oregon system for helping kids who have substance use disorder, co-occurring mental health is crumbling. But our kids are absolutely showing up with much higher acuity. We have found that when we give them an ACEs test, for example, we're getting scores of 9 and 10 on average across a group of 10 kids. And so they show up with much more severe mental health needs, which is not the traditional way we've seen kids in our treatment facilities. They've typically been, straight up SUD, but kids are now following what many adults do, which is they use substances and alcohol to numb their mental health issues. And so that for us requires a very different workforce in terms of their medical and psychiatric expertise and their mental health expertise.
9 and 10 is top of the charts. Like if you get over 4, you're starting to be in trouble, right?
Yeah.
Well, let's move to your first slide here, Marie. Tell us about what you have lined up. There's a lot going on here.
Yeah, so as we've been talking about, the pandemic has clearly worsened our behavioral health crisis. And in Oregon, we know we've seen some major changes in trends for overdose deaths. We're going to talk about those a little bit later. But really, given the need and the increased need, it's really imperative for the healthcare system to find ways to increase access to behavioral health, tough in an environment when we have a severe workforce shortage for those professionals, but we need to find ways to be creative. And maybe what I'm going to offer up today is a way to think about how to sort of get at two things at once. And so I want to talk about the fact that many of us are fully aware of the fact that emergency departments are crowded with individuals who have either diagnosed or undiagnosed use disorders. In fact, ED utilization rates for these individuals is significantly higher than the rest of the population. And if you look at the chart over to the right related to the frequency of ED visits, in 2015, Health Share of Oregon, which is one of our large managed care organizations in Oregon for Medicaid patients, this data shows that 14.5% of patients with one ED visit have an SUD diagnosis, while patients that have 10 ED visits, you see that ratio rising to 73.5% of those with 10 or more ED visits in a given year. So our ED staff is often faced with treating the presenting symptoms or putting patients in holding areas because the expertise is not typically ingrained in emergency departments to address these either diagnosed or undiagnosed substance use disorders. So we began a program in partnership with a local hospital emergency department system to have just one counselor in the ED who focused on having conversations with patients of this nature. And over the course of about 3.5 years, that one person had 738 conversations. They actually enrolled 36% of those patients they had conversations for. Previously, that conversation might not have happened in treatment. And of those who enrolled in treatment, we saw about a 48% completion of treatment, which is consistent and in some cases higher than what we see in the country for treatment completion rates. So we were really pleased with the results we're seeing in this program. There's only a couple programs in the state doing that right now, but I think it is a tool for us to access patients at their moment of greatest need and begin to show them the pathway and have the conversation for maybe thinking about treatment. And just because we felt like it was important to say, we did do a sort of quick back of the napkin calculation on the kind of costs we saved. And in the second chart, you can see the footnote there talks a little bit about, we estimated just on those 129 patients that completed treatment, we saved about $2.8 million in the healthcare system. So not only is this better care, it's also being done at lower costs, which sounds sort of familiar for many of us. Overall, these patients have multiple comorbidities. And so we definitely find the need to have other connections to programs and services that address their trauma or their significant social determinants of health, those kinds of things. So overall, I want to offer up this as a model for how we might smartly address accessing behavioral health starting at the emergency department.
So Paul, what do you make of models like this and specifically just the renewed understanding of the importance of applying behavioral health in the ER setting?
Well, it's a subject near and dear to my heart. My very first job for Providence was as an ER psychiatrist, and they, had this issue of, patients stacking up in the ER without the expertise. And so I spent many, many, many years doing that. And so I think, it's important. The ER is really the portal for acute care for most cities. And they're not typically trained, right, to deal with this. And so in our bigger hospitals, at least within Providence, we have a pretty nice, 24/7 crisis team trained to deal with folks, but we don't really have the time. There's time to kind of assess and make a judgment about what should happen next. And then the patients are just kind of sitting there. So I think it's an area that's really ripe for innovation. Providence is actually going to do a pilot with using some digital technology in the ER, leveraging evidence-based tools for both assessment and safety planning. So that's an area of interest for us. But I do think it's a really important place. It's also, I think, unfortunately, it is the portal, but it probably shouldn't be the portal. But for a variety of reasons, it is. Whether it's the solo therapist who has on their voicemail, go to the ER if there's an emergency. We get a lot of people landing there who probably didn't need to land there. So I think there's also an opportunity to look at who is landing there, who could be served elsewhere in other types of settings. I think, partially that's what the Unity PES was hoping to achieve on some level is directing folks to a specialized center. Who is it? Is it Cascadia has a walk-ins? Multnomah County and other counties have walk-in centers, so we can direct people away from the ER. The ER is not a very therapeutic space. I don't know if you've been to an ER, but it's noisy, it's busy, people are distracted, and so if you're having a mental health crisis, it's about the last place in the world you want to be. But it's often the first place that you're told to go. So I think it has to be emphasized as an area for innovation and diverting people to better settings.
Mike, I wonder what your thoughts are about our ERs and behavioral health in terms of workforce and the right scope of practice. Meaning, even if we had a psychiatrist for every conversation, it might not be that we want to have psychiatrists. Maybe it's not psychologists, maybe it's community health workers or some other MSW kind of credential. What are your thoughts on how to kind of level set the right credential for this need in the ER?
Well, I think you need a spectrum depending on what the presentation is of the patient. And, optimally, you would have various levels of expertise, but also strength. And expertise doesn't not necessarily correlate with level of education. And, Marie, I really love the data you presented here. And in Central Oregon, we've been fortunate that we've had some similar models of integration into the emergency departments where we've paired a CADC, a certified addictions counselor, with a recovery mentor, so a traditional health worker. So it's a dyad that is available in the emergency department to work with folks who are presenting with substance use disorders, who then can even engage them in the community, follow them into the community upon discharge. And then that's also coupled with requiring a higher level of education. Providers who are now actually doing buprenorphine inductions in the emergency department, so that when our patients, our members with opioid use disorders present, they don't necessarily get lost to follow-up because they can actually begin their treatment there. And there's some really excellent studies that came out a few years ago that demonstrate if you're able to do the buprenorphine induction at the time of the ED visit, your retention that you've got great statistics on this, Marie, but your retention just goes up really significantly. So I think it's a multidisciplinary team. I am a real believer in integrated settings. I do have concerns about standalone, siloed behavioral health, certainly in the emergency department. And I do think the best way to meet these members' needs is to really have a multidisciplinary team and that can address the medical and the behavioral health, because more and more these patients come with medical complexity. And we need to be able to treat them holistically in that setting and have an integrated team, just like we're starting to do in primary care. We need to do that in the EDs as well as other settings like med-surg units, ICUs, even NICUs. There's just incredible opportunity to infuse behavioral professionals into these traditional medical settings.
Elise Thompson says, great to hear about the work you're doing in Central Oregon, Mike. And I'm going to integrate some of these questions into our conversation here moving forward. But Paul, you had your team's, your hand raised here. I want to make sure you get a chance to jump in.
Yeah, I just wanted to redouble some of the comments that Mike just made about the care team. I mentioned that I started as an ER psychiatrist, which is true. And I think at the time, the thought was, well, we don't know what to do. Let's hire a psychiatrist. And they already had social workers, in the ER. And my role evolved over time. And I just want to really emphasize what Mike says, is that the key really is multidisciplinary team. And the role of a psychiatrist really is a small sliver. I think it's 10% of the work. the bulk of the work, 90% of the good work, is going to be done by a really well-trained, like master's level clinical social worker, LPC type person who's in the weeds, knows the community resources, knows motivational interviewing, knows collaborative problem solving, and can work with people. And I was there for supervision, for medicine, for maybe legal forensic consultation. And so I think that's the right model. I don't think the right model is put a psychiatrist in every ER. I think Mike can probably attest to this. We didn't get really super well trained in how to manage emergencies in training. And the average psychiatrist has variable experience doing that. And so you really want to count on those kind of battle hardened, if you will. And I say that with much love and respect to my social worker friends, because they are the best. And that's the backbone of the crisis team.
I want to jump to our next slide, but first I want to get this comment in from Julia Brown. She has a question that any of you can jump in and speak to. She says, first, I work with youth primarily in Multnomah County. While the emergency departments have gotten better about trauma-informed care, kids continue to get stuck in the emergency department because there's no access to psych residential or acute inpatient services. This leads back to the ED, eventually discharging kids back home to the community, even though they often escalate again and return back to the emergency room. And the cycle continues, she says. In my opinion, she says, we desperately need much easier access to residential treatment to stabilize youth mental health and transition them back to community-based services. So is funding residential treatment that is Medicaid funded, she asks, a priority right now in Oregon? Any of you want to take this sort of fiscal policy question and speak to it?
I can start, but try not to take too long here. So yeah, absolutely. There is an access pinch with higher levels of care in the child behavioral health world, and there are some dollars. In fact, there's some pretty big announcements today out of the legislature of some how these dollars may be earmarked or tagged for expenditure to include higher level behavioral health services and access both for adults and for kids. So there's some good news. There's some resources becoming available to help support that. But we do need to attack this issue from both ends, right? It's just not about building capacity at the most intensive, expensive, highest end of the spectrum. It's also about starting with prevention, but certainly building in those community-based services that can also be very intense, but allow the child to remain at home with natural supports in their own community. And I think if we build that system up better too, we also take pressure off the need for these kids to go up to residential or subacute or inpatient level of stay. So Oregon recently rolled out the IIBHT, or Intensive In-Home Behavioral Health Treatment. It's a new model of treatment that includes having a psychiatrist or psych nurse practitioner attached to the team and really provides very intensive services, really for the full purpose of keeping the kid in the home, those children that are at risk of being removed from the home for whatever reasons, are going to a higher level of care or even into DHS guardianship. So that's just getting rolled out. But more work like that to build these services so that the kids can remain in the community. It's not going to keep them all from going to higher levels of care, but it's one part of the solution, as is building more capacity at the higher end.
Great stuff. I want to transition to this next slide and have you, Paul, speak to what's going on here.
Great. So, as we think about COVID, I wanted to point out that, before COVID, what was on everybody's mind and a key focus for us and my own work at Providence was issue around suicide and overdose deaths. The so-called deaths of despair. Which is a term coined by an economist, not a psychiatrist, by the way. So that's another story. But we're very concerned about that. And obviously, this slide references accidental drug overdose deaths through 2018, and this is labeled as accidental. Maybe hard to know every single one, but you can obviously see the trends, and the trends are not hugely surprising. You can see the rise, and this is sad for me. I started my medical training in 1997, right at the era of pain is the fifth vital sign, and America entered into this somewhat disastrous relationship with opiates for pain, which is represented here by accidental deaths by prescriptions, increasing by 5 to 6 fold, and then over time having that drop. And what we saw is that the rates of these overdoses was increasing. Prescribed opiates were coming down, but we saw a big time increase in heroin overdose relative to 05, as well as synthetic. And you've read about fentanyl and other synthetic opiates being very, very dangerous. Police find it on a raid and get it on their clothes and can overdose. So this stuff is really lethal. And then the other thing that's notable is methamphetamines, and we were seeing this at Providence in the delivery side in our ERs. The meth, people coming in with meth-related psychosis or agitation was just doubling, tripling over prior years, and a lot of these are deaths by overdose. You don't usually think about meth being a cause of death, but probably co-administered with other things like opiates, which probably represents increased use. So prior to COVID, we're worried about overdoses. We're worried about opiates. We were thinking about naloxone, and I think as the dust settles around COVID, I think we need to really, understand what's going on in that demographic. Are we providing MAT? I think one concern I have looking at this is, when I see heroin and synthetic opiates going up as a trend, even though prescription opiates are coming down, to me that says we don't have access to medication-assisted treatment to the degree that we need it. And we know that that's the case. I think it's increasing, but it's kind of a trickle where it really needs to be, a fire hose. So, anyways, this is kind of pre-COVID setup. It's still with us. I think we got distracted by COVID, and people are more resilient than we give credit for. I don't think the generations, maybe they'll be more resilient because they had to tough it out in high school. So let's not forget about strength-based views. But I am concerned about this. And as the dust settles, we're going to be collecting data. Part of the challenge we have at the health plan now is it's a new service line for us. So the data is starting to trickle in now. In 6 to 12 months, I'll be able to speak better to what we're seeing.
Marie, what are your thoughts? In fact, you were giving voice to this recent OHA announcement and study that said they saw a 40% increase in deaths related to opioid use during the first part of the 2020 pandemic. How are you seeing opioids and substance abuse impact or play out with your patients at DePaul?
Well, we are absolutely, as not shown by the last few years on this chart, we are seeing a decline in opioids and a rise in meth related to treatment needs. Alarming. And of course, meth combined with other substances, it's really quite scary. And there's a lot of work to be done. We need to really double down and figure out how we're going to address this trend. I can't say we have the answers yet.
Are we, I will hear, Mike, maybe you could take a crack at this. I hear from folks like, yes, the opioid issue is a concern, but it's really street drugs like meth, like heroin, that are causing degradation in quality of life, in actual life, and that problem is a much greater problem. Do you see that same sort of, or would you refute that claim based on the data that you see? What do you make of that?
So the short answer would be that it's a combination is my impression from what I see in our membership and from what I read in the data. But I would say, opioids are street drugs now too, right? I mean, so when you say street drug, how do we define that? The fentanyl that's out there that's being packaged as heroin. I mean, opioids are now through synthetic processes, street drugs, where it was the prescription drugs were really pushing it early on, combined with heroin, going back decades. Now it's less the prescriptive drugs, and it's the street drug version of the opioids that are now so lethal. So I'm very concerned about both methamphetamine and opioids in all its different forms, driving increased deaths as well as just the morbidity and the social detriments that come with that use.
Let's see if we can keep this conversation going in regards to your slide here next, Mike. Why don't you, walk us through your slide, and then we'll circle back to this topic around substance abuse.
Sure. So a little self-disclosure here. I'm colorblind. So I had my 9-year-old come up here just before we got started and pointed to the bars and told me what colors they are. So let me see if I can keep them straight for you. And I'm probably going to spend my time explaining this slide, just the logistics of it, because it's a little bit complicated, and then we can have a good conversation about it. But this is data from PacificSource. I decided just to use our entire enterprise membership, which is somewhere north of 550,000 members. We're in 4 states. Well over 400,000 of those members are in Oregon. So this is heavily weighted towards Oregon, and kind of a mix of predominantly commercial and Medicaid, but a little bit of Medicare Advantage as well. So what you see here, and this is all about telehealth essentially, and the contrast with face-to-face rendered services. So starting with that top line to the left, I believe that one is red. That's our face-to-face office visits for E&M services. So this would be your traditional like new patient and follow-up patient visits with physicians, PAs, and nurse practitioners. And you can see that January 2000 hit, and by the way, that dotted line is there because we quadrupled our Medicaid membership, and that's why in the background you see our overall membership climb dramatically at that point. That's kind of an artifact. But just beyond that January 2020, as you start to hit February and the onset of COVID, you see that dramatic drop off as far as what percent of all of our or of many of our visits are made up of these face-to-face E&M visits. So let's go down to the orange line, which is next, going left to right. You see a similar drop off, kind of mirrors that, and these are the psychotherapy face-to-face visits that were occurring, which were about 25% of this span of it between E&M visits and behavioral psychotherapy visits. And then you go to the bottom line, the blue line down there, it's really actually well less than 1%. And we saw, as you go to the right there, truly over a 200-fold increase in telehealth services. And then you can see it jumped in this chart to 71% of all services and kind of peaked right there around April of 2020. And then after that, you see that the telehealth overall goes down, and these are all telehealth services as defined by certain modifiers or point of service numbers that you would put on the code to identify it as such. It begins to level out, and you can see it stayed fairly level, but at a much higher rate. So telehealth is here to stay with us. And at the same time, you see a little bit of the rebound of the office face-to-face visits, so that they're about equal in the proportion of the visits on that graph. But what you see with the behavioral health visits is a little bit of a drop off, but it is also still maintaining pretty strongly. And then if you go to the right, this is really then just looking at the distribution of telehealth services specifically. And what you see is that while telehealth services even pre-COVID were majority for behavioral health services, now it's even more so. So now 80% of all telehealth services are behavioral health, which is the top line. The black line is essentially all other services, including phone calls that can be used for telehealth. And then the teal line are the telehealth E&M visits, which are about 15%. So I think this probably tells you something you may have already thought you knew, but it graphically, I think it's very impressive. And for me, it brings up a lot of issues. First of all, it's wonderful that we've increased access by really moving towards a virtual world for delivery of healthcare, including behavioral healthcare. But it does bring up questions around quality of care, as well as health equity, that I think are quite controversial. And in the space of quality of care, we have this notion, and some of you may have heard me talk about it at a previous state of reform talk, about our decision, or the decision of the state, and the feds have not yet weighed in, but post-emergency, are we going to treat voice-only visits the exact same way we do synchronized video and voice only. And specifically, are we going to reimburse it the same so that they are considered of equal value? Not that there isn't a role for voice only, but it's just something to consider. Is that really of equal value? Pacific Source has long paid for synchronized video services the same as face-to-face services. So that's been shown to be pretty equivalent to face-to-face as far as quality, and in some cases even preferential by members and patients. On the health equity piece, there's a similar issue related to this. Is we now have a new virtual office, right? It's not just the brick and mortar office, but we have a virtual office, and the access to that is not equitable across the population, especially in our more marginalized population. There's challenges with data plans, with hardware, with software, with even connection to the internet. So how do we get these folks equitable access to the new virtual office? And I would suggest that, in the Medicaid line of business, we have a non-emergency medical transport to get them to the brick and mortar office, right? That's how we get them there. And maybe we need to think about what's going to be the new benefit, or what's going to be the new investment that gets them on the digital highway to the virtual office that's equitable for everyone. And I think that's a challenge that's before us right now.
Yeah, interesting idea that we need a non-emergency medical, I don't know what we call that, transportation on the digital information superhighway or something, some way to get people the ability to manage their health through increased broadband or access is interesting. Paul, let me ask you, I assume your data at Providence largely mirrors this data. How does treating substance use, how is that fitting in this new world where behavioral health is such a high proportion of telehealth visits?
Well, I think behavioral health delivered via tele is and can be very successful. I mean, I think the reason you're seeing, that one slide that Mike referred to is you're seeing telehealth is the majority of telehealth is behavioral health, and that's because you can get 98% of what you can get in person. People would argue that, and I have colleagues that work in very specific settings, like an ER or inpatient, that would say, I'd feel really uncomfortable evaluating somebody who was delirious or somebody who was like really super high suicide risk, where I really want to understand body language and the like. But if you're seeing kind of a typical outpatient who's able to go home at the end of the visit, you can replicate such a high level of what's done in person that I agree with what Mike said, that they're essentially, for all purposes, equivalent services. So I think it's a great tool. One of the things that we saw at Providence as the pandemic hit and we switched, just like Mike showed here with this, we did the same thing. We had like a 300% increase in tele. Our no-show rates went down. Our fill rates went up. More people are accessing care. I mean, you just think about it, it's common sense. People don't have to go to their car, find parking, get a babysitter. And so some ways I think that this, it is a little more egalitarian in the sense that it reduces barriers for people accessing care who may have problems with, transpo or other things like that. But I echo Mike's concerns that if you're, super low income or you don't speak English, that you're going to be kind of second-class citizen if everything is tele. So I do think that we need two things. One, like Mike said, we need a way to get people plugged in to the tele platform, whether that's getting them a ride to a clinic that has a tele setup that they can sit and do the tele visit at a clinic. That's actually how tele was originally set up in rural communities, right? You had to go to the clinic, and so maybe thinking about that. And then the other thing would be to, we really have to consider how do we deal with the language barrier and the technology barrier. I mean, we had a program where we were sending people we were doing geriatric evaluations. And, if you're 82 with minimal cognitive impairment, you're not going to be able to log on to a WebEx meeting, right? So do we enlist family members, or is that part of the healthcare workforce's job to go out with the tablet and get people connected? So I think we have questions to answer there, but I think it's successful. And in some ways, it has a chance to be more successful than brick and mortar. Eric Topol wrote a book in, I think it was 08 or maybe it was 2014, called The Patient Will See You Now. And, the medical establishment has long been about what's convenient for us. You come to us, you see us when we're ready. And I think, most of industry has switched away from that. Mobile banking, on-demand video. I think medicine it's conservative. It's going to be slow to adapt, but it's coming. And I think that COVID was a catalyst.
So, Marie, let me ask you this question that comes in from Philip Hawley. He says, in regards to telehealth for behavioral health, is this mandated, or is it truly about patient choice about what format they would like their visit? He says, I know that we had no in-person options for during the pandemic in 2020, but now we're trying to see what preferences truly are as all options are on the table. So for your line of service at DePaul, telehealth seems like, and I think Mike's data reinforces it, that telehealth is going to be around for a while. But where do people prefer to have human contact, in-person contact, compared to telehealth in your clinical experience?
Yeah, so first of all, I agree, telehealth is absolutely here to stay, but we were fully converted on all our outpatient services to providing telehealth services by the end of last March. And so our clinicians have been working in a telehealth environment now for almost 14 months. And I can tell you that while at first telehealth for us seemed to be like, it's a dream, right? We have been down this path now in long enough to identify there's also some significant problems. So we intend to go forward with providing both and giving the patient the choice, much along what Dr. Geiger has suggested, because there are absolutely some patients who are going to always do better in a face-to-face versus telehealth environment. And in particular, we've seen some alarming, clearly they're under the influence when they're in a group, for example. And, that just doesn't happen when you're in a face-to-face environment. So it does present some trickiness for clinicians. And we definitely know we need to be providing both going forward.
I want to move on to our last slide here. And this is one that we contributed to the conversation. And the long and the short of this graph, you can see a lot of different bars here, but the primary question is, did your provider talk to you? Were you asked about things like your mental health or substance abuse? Some of these questions you'll see, did your provider talk to you about losing weight? And in many cases, the primary care provider did, 47%. That's the first column on the left. How to reduce my risk for diabetes. That's near the right side. Interesting to me, 25% of primary care physicians or providers asked about diabetes. Only 4% of mental health providers did. And I have the idea that because of ACEs and other things, that our body weight is sometimes connected to our mental health, and as we get bigger, we are more likely to have diabetic complications as our BMI increases. So things like ask me if I gamble. Primary care providers only 13% of the time. So I wonder if we're thinking about how we can build a better behavioral health system and build a better healthcare system in general. At some point, you would think that we would get better about asking some of these questions, particularly at the primary care setting, but also as we start to think of mental health as a primary care, at least a lot of mental health as a primary care adjacent kind of service. So I'm wondering what any of you think about this. And Mike, I'll ask you first. Thoughts about whether primary care should be asking more often about some of these, whether that, I guess maybe just what your reaction is when you see some of this data.
Yeah, absolutely. And behavioral health is primary care too, right? So primary care really these days, you just can't think of it without conceptualizing it as medical and behavioral health whole patient care. And there's various ways of delivering that. And I think our primary care providers on the whole have really done a great job upskilling themselves, learning more about behavioral health, and becoming even more expert behavioral health providers than they already were. Because, I think about 70%, at least 50% of any primary care visit has some behavioral health component in it. So it is incumbent upon our, medical providers to be asking these questions. But in the integrated model that's the primary integrated model that's been adopted by Oregon, not necessarily elsewhere, is this primary care behavioral health model that does add a behavioral health consultant or behavioral professional as an embedded, integrated part of the primary care team. They're not co-located, they are part of the team. So there is this opportunity, maybe through some screening, and perhaps the primary care provider isn't even asking all the questions, where that patient can get seen by the BHC, that behavioral health consultant, and get some of the behavioral health issues addressed still as part of the primary care team. So it'd be interesting to maybe change these questions to, do you get these questions asked in your primary care office? And do you get these questions asked in your behavioral health office? And ultimately, where we need to be going is that it doesn't matter which one, you will get these questions asked, because the vast majority, 70% of our population, at least with behavioral health conditions, should be able to get a lot of their treatment done in a medical setting, such as primary care, for mild to moderate conditions, right? And yet there is going to be a subset of the deeper end of the population, that 10 to 30%, that do need to be in a specialty behavioral health clinic. And a lot of those folks would benefit from a behavioral health home in that setting, where they also get their medical care. So I would love to change the question, follow that over time, and see if they're getting comprehensive care in either setting.
Yeah, great, good stuff. I know we're getting short on time. We try to end 5 minutes before the hour, and we're bumping up against that. I want to ask just two more questions that have come in from our audience. And Marie, let me ask you this question first from Emily Berger. She asks, is living through COVID going to be an adverse childhood experience? And what does the data tell us on this subject? Do you think that's the kind of thing that should be added to the ACEs list?
Boy, I am not the person to ask. I'm sorry, but I'm not even gonna go there.
I have two psychiatrists on the line, so to speak. I could ask either one of them. Paul, do you have an opinion on this one?
I think it's maybe a little bit early. I mean, part of what landed something on the ACEs list was research tying specific types of exposure to outcomes. Sexual abuse, neglect, observation of domestic violence. I mean, those things have been studied and been, proven to be linked to outcomes. So I think the jury's out. I am a little bit more of an optimist. I mean, I think for sure there are going to be people for whom this world event has been a horrible experience. Their families, both parents lose their jobs. Mom develops an alcohol problem. They fall behind in school. I mean, there's definitely folks that are going to have suffered from this. Yeah. It's also a stress. Sometimes people respond to stress by getting stronger, pulling together, getting closer to their community, developing skills. Suicide rates fall during wartime. People pull together, and this is kind of a universally noted thing in world psychiatry. So in times of stress, people can pull together. So I'm kind of mixed on it. We'll see. But I'm an optimist, I tend towards more of a strength-based resilience model, as opposed to everybody's doomed and people are going to be jumping off of buildings next year.
Well, we'll leave it with that. Thank you guys for doing this. I know we could have spent another hour talking about this stuff. I know people would have stuck with us, but I want to respect your time, respect our audience's time, and make sure people can get on with their day. So Marie Wacker, CEO of DePaul Treatment Centers, Dr. Mike Franz, Medical Director for Behavioral Health at Franz, at Pacific Source, and Dr. Paul Geiger, Behavioral Health, or Medical Director for Behavioral Health at Providence Health Plans. Thank you all for being here, and thank you again to Care Oregon for underwriting this. We appreciate it. We'll post this on our site so people can come back and watch it again. And thanks again for letting us play this role in Oregon healthcare. We appreciate it. Take care.